Welcome, everybody. Welcome to another episode of PEM Rules. I'm your host, Yaron Ivan, as usual. And today I'd like to discuss an interesting and somewhat unfortunate clinical case that I think we can all learn from. A few weeks ago, I was contacted by a PEM Rule listener who had an unfortunate incident in the pediatric emergency department with a patient. It was an infectious disease presentation, which is why I thought we can bring back Fatma Levent, the pediatric infectious disease specialist, a former colleague of mine, to discuss the case and see how we can all learn from the outcome and do the best we can do for our patients with fever for 5 days or more. So, thank you, Fatma, for coming to the show again. And I'm not going to introduce you with all the details. I'm briefly going to say that if you don't know Fatma, you should listen to episode 25, recorded in November of 21, where Fatma and I discussed antibiotic stewardship and the presentation of febrile child in the pediatric emergency department. So today, Fatma is back on PEM Rules, and we're going to discuss the very concerning or very puzzling patients who come to the pediatric emergency department with fever for 5 days or more. Fatma, welcome back. How are you?
I'm good. Thank you so much for having me. I appreciate you.
Thank you very much for coming again. I always teach the residents fever and infectious disease is what I do at least 50% of my time. It's probably the things that keep me busy the most. So it's always good to have the expertise of someone like you. And I want to share with you a little story, Fatma, of a fan of PEM Rules who contacted me through the website. And she had a very frustrating experience. She is a PEM clinician. And a few months ago, she contacted me after she had a patient, a healthy, otherwise vaccinated 4-year-old female, who came with fever for about 5 to 6 days. The child, according to her, was well appearing, had normal vital signs with no inappropriate tachycardia. In other words, the kid was appropriately tachycardic for the temperature that she had. By history, the child had no respiratory symptoms whatsoever. She wasn't coughing, she wasn't dyspneic. And due to the lack of respiratory symptoms, my colleague or fan that contacted me through the website obtained a urine analysis to rule out UTI because the kid had no respiratory symptoms, which I agree with. And after the urine was negative, after the vitals looked fine, she discharged the child, observed her for a little bit, discharged her home, and that same child came back 24 hours later with significant respiratory distress. Chest x-ray was positive for quite a bad pneumonia. The kid ended up in the PICU, needed a chest tube, and the PEM Rule listener who contacted me wanted me to discuss the story and share the story on PEM Rules for other people to learn. I figured it would be a good topic to discuss. I got to tell you, Fatma, as a PEM physician, when I think about fever for 5 days, I always worry about Kawasaki. I feel, though, Kawasaki is fairly easy to rule out with good history and physical. If the kid has no strawberry tongue, no mucous membrane changes, no lymphadenopathy, no conjunctivitis, I don't really worry about Kawasaki. I document very well, and I don't worry about it. Sure, there is the notion of incomplete Kawasaki that certainly make things more challenging, but I feel like Kawasaki is something that you can rule out fairly well with history and physical. Do you agree with that? Do you agree with that point, first of all?
Yes, definitely agree with all of your comments. And it is unfortunate that your colleague has seen this case, but it is not uncommon to see these kind of cases, because if you see them very early in the course, sometimes a lot of things can be very vague. So for Kawasaki specifically, there are very good guidelines and algorithms that you can follow. If you're calling it incomplete or atypical Kawasaki, sometimes it gets a little bit more vague, but it's usually pretty straightforward, as you mentioned. And in this era, we can find some viruses on some of these kids that are positive sometimes, like enterovirus. Rhinovirus is a very common one that you can see, but having a PCR shouldn't exclude the Kawasaki, so you should still look for the clinical guidelines of how to approach Kawasaki. But usually it is pretty straightforward on those cases. but you should also look for other causes. Kawasaki is just one of the differential.
All right, very good. My next question to you, and again, I don't disagree with the physician who contacted me. I would have done the same thing, but she obtained a urine analysis because the child was febrile, with no respiratory-like or viral-like symptoms. The kid was a female, so it seems appropriate. But my question to you, and if you know, how many kids with UTI present with prolonged fever? The topic for today is fever for 5 days or more, with no frequency, urgency, dysuria, and all those symptoms that we learn in medical school are strongly associated with UTI. And my other question is UTI indeed the most common SBI these days? Because we have vaccines for pneumonia, we have vaccines for bacteremia, even hepatitis media. Is it true? Is it a right move of us PEM clinicians to worry about UTI first and foremost?
So, I definitely agree with how you were placing those questions. So, UTI is common. We usually see the presentation with the symptoms that you mentioned. However, sometimes you can have younger patients, especially not verbalizing what they're feeling, or it might be early enough that they're not seeing some of those. I think it was appropriate to check the UA. And, sometimes with Kawasaki disease, you can see sterile pyuria. So you can maybe pick up some of those issues, like the urine analysis might look abnormal as well. But, in this post-COVID era, we're seeing a lot more other things too. So as you mentioned, we have really good vaccines that protect against strep pneumo and, H flu and some of those other bacteria. But, one of the things that we have been seeing with the pandemic and post-pandemic times, people are getting vaccinated less. So we are having kids that are not fully vaccinated, missing their vaccines, or not vaccinated at all because the parents are scared now, then they're not doing any more vaccines. So definitely the numbers have gotten lower. We have seen kids who had pneumonia or otitis media with strep pneumo. We have seen kids with H flu, but non-type B. So, a lot of other things can happen too. And then one of the other emerging infections we have been seeing is group A strep. And this is the one that causes invasive group A strep infections. The CDC is still working on it. We don't have the final call, but it started in Europe and then came to North areas. We have seen it in the area quite a bit. And I know that it's probably all over right now. It causes pneumonia, causes bone and joint infections, really deep cellulitis, necrotizing fasciitis. So it is out there. And sometimes some of these kids look fine until they don't, especially younger kids. So recommending that they follow up if things don't look right. I understand the concern initially when everything looks good, you've checked the UA, everything looks great, and you may have gotten a blood culture or not. But I think it is appropriate to send them home if everything looks normal. Your CBC might help you, your procalcitonin or CRP might help you on some of those. So having extra information and having a very good history and physical definitely is important too.
All right, very good. Great advice. Just quickly, briefly, because you mentioned the group A strep that we're seeing, the pneumococcal conjugate vaccine that we have is useless against?
Yes, so there's no vaccine that would protect you against group A strep. This has been going on for years and years. We have seen it, but interestingly, we're not sure why it is happening now. They're thinking it's the same bacteria. Is it the host response that's causing this type of problems, or is it a different type of strep, group A strep? We don't know that yet.
Very interesting. Yeah, so that's unfortunate to hear. Going back, Fatma, going back to the story that started it all, that I got from the PEM Rule listener. Again, thinking about the story and the case, I don't think I would have gotten a chest X-ray on a child that has fever for more than 5 days, who has no respiratory symptoms. And I don't think I was very familiar at all with the notion or the diagnosis of occult pneumonia, a child with a fever only, with no cough, no congestion, no hypoxia, no difficulty breathing, normal auscultation. Can you teach us a little bit more about that entity, occult pneumonia?
I think you all have heard about occult bacteremia. So it's just the bacteria goes into the bloodstream, you catch that, and they might have sepsis with it or not, and they may not look as sick. So this is in the similar pattern. I'm going to take a different route and say that this was probably early pneumonia. And, it is possible that clinically you might see some of the other things coming into, like, breathing difficulty, or, tachypnea might come a little later as well. So I think in this case, the tachycardia was a little bit unusual. And of course, the prolonged fevers, and, sometimes you can add on some labs. And, I don't want you to do labs on everyone, but if you've had fevers for more than 5 days, I think it's reasonable to do a CBC. You can add the procalcitonin that goes more with bacterial infections than just the CRP. Sometimes we check both to help you out. I really don't like treating numbers, so I really like looking at the patient and treating the patient, but these are things that can be helpful. And sometimes you don't get the chest x-ray. Listening appropriately and doing a good physical exam and documenting that, and then maybe asking for a hospital follow-up soon if you're concerned, if anything that's bothering you with this patient, or let them come back if the fever continues and things are not improving.
Very good. And with regards to those of us who were lucky enough to get an x-ray and diagnose pneumonia, assuming the child is not hypoxic, tolerating fluids, and is not in any distress, do we still agree that high dose amoxicillin is the appropriate outpatient therapy, or IV ampicillin if the child is coming in? Or should we start all those kids on ceftriaxone concerning for resistant pneumococcus?
I would actually shoot for ampicillin or amoxicillin. High dose is very appropriate at this time, unless you have an unimmunized child or someone who has had recurrent infections that you're concerned that there's some problems, like unison or ceftriaxone might be appropriate for those patients. I would say just your normal approach should be ampicillin inpatient, amoxicillin high dose outpatient. And you can do 10 to 14 days. There are some studies now showing even shorter periods, like down to, I've heard, even 3 to 5 days might be appropriate for pneumonias. I don't think we're there yet, but I feel like in the future, you're going to see more and more studies come up. I know in the adult population, they were down to about 5 days of community acquired pneumonia. I feel like with kids, we are still doing a little bit longer, and I think 10 days is a good length of therapy for these patients. I feel like the most important thing is to be able to recognize it, start your medicine, and make sure that they're able to take it. Because if you prescribe amoxicillin, they're vomiting, they're not taking anything by mouth, and they're lethargic, that is not going to work very well.
Sure. Last question with regards to the antibiotic therapy. And again, something that I see quite often, it doesn't make a whole lot of sense to me. I try not to do it, but those kids who come to the ER with diagnosed pneumonia, they get one dose of ceftriaxone that covers them for 24 hours, so to speak, and then a prescription for amoxicillin, which, please correct me if I'm wrong, to me doesn't make a whole lot of sense, because you're giving medication X one dose, you're not reaching a steady state. The next day, you started a totally different medication, and now you restart the steady state. Is that the right approach? Is that the wrong approach? What do you recommend we do?
You point out actually a very good point there. So, what they're trying to do is, in my mind, to cover them for 24 hours in case there is a bacteremia. So if you have a patient that is concerned, like younger than 3 months, immunocompromised, unimmunized, anything that is with a higher risk of bacteremia, I think it's appropriate to do that. Ceftriaxone will cover, it's just one shot or one IV medicine, and that works for 24 hours. If the blood culture remains negative, I think they're thinking like us, amoxicillin should treat it appropriately. So that's probably what I'm thinking they are considering there.
All right.
So it's not totally wrong. I would say you can do it on patients with higher risk.
So those patients that you're concerned about, possible pneumonia and bacteremia.
Right. Bacteremia is probably what they're using it. I know that a lot of people are using it even without concerns of bacteremia. Sure. But also the other option would be like if they're vomiting, they're not able to take any medicine by mouth. So that's another good place. You can give them IV fluids and make sure they're covered and they can start it tomorrow. I think that's appropriate too. But if possible, we all should consider, we talk quite a bit about inpatient, but also outpatient antibiotic stewardship. Absolutely. Because we are seeing increased resistance on many other bacteria too.
Absolutely. Fatma, thank you so much again for coming on the show. Like I said, infectious disease is what we PEM clinicians do at least 50% of our time. So your pearls and wisdom is truly appreciated, very helpful. And as usual, I'd like to follow the PEM rule tradition and play the music for the outro of your choice. And you make things very easy because I guess you were a teenager in the 90s. Is that right?
It is right, definitely.
Super easy. And you wanted to hear a song by Guns N' Roses, something like Knock on Heaven Doors?
Yes. Thank you so much. And I appreciate you having me again. This is a lot of fun. Thank you.
Again, thank you very much. And hopefully we can do that again. Stay safe in Florida and stay cool.
I appreciate it. You too. Thank you so much.
Thank you very much.
Bye.
And that is it for today, guys. Thank you very much for listening to PEM Rules and supporting the podcast and the website. Please continue to write with any feedback you have, or if you want to come on the show and present an interesting case. This is Knock on Heaven Doors, the Guns N' Roses version. Hope you like it. Have a great day.